Developmental anomalies of the external ear include preauricular sinus. The opening of a preauricular sinus is found in front of the helix, leading into a sinus tract lined with squamous epithelium. The tract lies in the subcutaneous tissues lateral to the temporalis fascia superiorly and parotid fascia inferiorly, with a tortuous and branching course. The terminal portion of the tract is adherent to the cartilage of the helix. Preauricular sinuses are postulated to develop from defective or incomplete fusion of the helix of his during auricular embryogenesis. An alternative theory suggests that isolated or localized folding of ectoderm during auricular embryogenesis is the cause of preauricular sinus formation. Preauricular sinuses occur sporadically or may be inherited. Sporadic abnormalities are generally unilateral, while bilateral preauricular sinuses are more likely inherited. Preauricular sinuses may be associated with several syndromes, most notably branchio-oto-renal syndrome. It has been suggested that preauricular sinuses may be linked with anomalies in the region of chromosome 8q11.1, q13.3. Renal anomalies are commonly associated with external ear anomalies, particularly preauricular sinuses, with these patients often investigated using renal ultrasound to detect concurrent renal abnormalities. To aid selection of patients for renal ultrasonography, the following criteria have been established: maternal history of gestational diabetes, family history of ear anomalies or hearing loss, associated craniofacial abnormalities, associated cardiac abnormalities, associated gastrointestinal abnormalities, and associated limb abnormalities. A preauricular sinus, or any other external ear abnormality associated with any of the above findings, is an indication for a renal ultrasound. The decision to operate is usually influenced by the frequency and severity of infective episodes, chronicity of sinus discharge, and the development of unsightly overlying skin inflammation. Incision and drainage should be avoided in acute infections due to the risk of sinus disruption and seeding, and less likely facial nerve injury. Acute infections are best treated with intravenous antibiotics, and in severe cases, needle aspiration with microbiology culture of the aspirate. Several techniques have been suggested for excising preauricular sinuses, including curettage, microdissection, and wide local excision. When selecting a surgical technique, it is important to consider that the sinus may branch extensively and be adherent to the pinna cartilage. Curettage is no longer routinely performed due to high recurrence rates and unsightly scarring. Microdissection techniques rely upon identification of the extent of the sinus and its branches, with lacrimal probes and methylene blue being used to delineate the sinus. The suprauricular approach involves identification of the plane of the temporalis fascia and dissection of the soft tissue between this plane and the helix of the pinna, remaining posterior to the parotid fascia, and without a formal attempt to identify the extent of the sinus and its branches. The resultant wide local excision is considered to give the lowest recurrence rate. Care must be taken to avoid facial nerve injury in revision cases and when skin and soft tissue inflammation is extensive.